will start, and I would like to draw your attention for the possibility of a non-recurrent laryngeal nerve during thyroid surgery. And I will start by making a small introduction and explaining the anatomy. So the thyroid gland originates from the first pharyngeal arc and the recurrent laryngeal nerve from the sixth. The recurrent laryngeal nerve, also known as inferior laryngeal nerve, innervates all laryngeal muscles except cricothyroid and is responsible for sensation of larynx below the vocal cords. So after widening around the aortic arc on left and the right subclavian artery on the right, the recurrent laryngeal nerve courses supramedially, and in 72% of cases, this nerve divides in more branches before entering the larynx, and the more anterior ones carries the most motor fibers, and for that, these are the branches that should be preserved during thyroid surgery. In this diagram, I show the normal anatomy of the embryological development of the recurrent laryngeal nerve that, as I said before, originates from the sixth pharyngeal arc. So, regarding the embryological development, when the heart descends, the nerve hooks around the sixth aortic arc and ascends again to the larynx, and this is what accounts for the recurrence course. On the right, when the distal part of the sixth aortic arc disappears, the nerve will move up and hooks around the right subclavian artery. And on the left, since the distal part of the sixth aortic arc doesn't disappear, so the nerve doesn't move up and will persist as the form of the ligamento arteriosum. That's why the nerve doesn't move up on the right. So the non-recurrent laryngeal nerve has a very small incidence. And why does it happen? It happens because the fourth arc disappears. So the subclavian artery will have a different origin. It will originate directly from aorta and will cross behind the esophagus, and that is responsible for, in 5% of cases, for dysphagia. On the left side is even less frequently and is associated with situs inversus. So the non-recurrent laryngeal nerve divides in two types. Type 1, when the nerve runs with the superior vascular pedicle, as you can see in the image, and the type 2 splits in two subtypes. 2A, when it runs above the trunk of the inferior thyroid artery, and 2B, when it runs below or between the branches of the inferior thyroid artery. So we should consider the possibility of a non-recurrent laryngeal nerve. It's rare, but it's possible. So we should always, during surgery, identify the nerve. And based on the usual anatomical landmarks, and always in mind with the anatomical variation, and we have other arms to use to identify the nerve, like the intraoperative neuromonitoring, and the knowledge of its presence and the current surgical technique will minimize morbidity. So I'll show you our clinical case, a male patient with 64 years old with a right thyroid lobe nodule of 4 centimeters that denied dysphagia or hoarseness. He didn't have any history of family thyroid cancer. He didn't have radiation exposure. And on the ultrasound, revealed a nodule with almost 4 centimeters or in the right lobe. The fine needle aspiration cytology that we do guided by ultrasound revealed a Hurtle cell tumor. And in the next CT, we also saw another thing. We saw that we had an arteria lusoria. Arteria lusoria is when the right subclavian artery arises from the left. So we had a preoperative suspicion of a non-recurrent laryngeal nerve. The anatomical pathology revealed carcinoma, papillary carcinoma, and here we have the images. So we see here the right lobe enlargement, and here the origin of the right subclavian artery from the left, behind the esophagus. Once again, the origin of the right subclavian artery on the left. This image is not from our clinical case, but I would like to show you another vascular anomaly that is also associated with non-recurrent laryngeal nerve. This one. When we have a common trunk for the common carotids, when it's common, we must also think that we might have a non-recurrent laryngeal nerve. Here we have some pictures of the surgery. This is from our surgery. It's not very good in this slide, I'm sorry. But here we see better, and it's the same case here from a 2A type of non-recurrent laryngeal nerve, and here type 1, because it goes along with the upper, with the artery thyroid. So, in conclusion, the non-recurrent laryngeal nerve is very rare, but when present is of major risk of damage. And it is associated with vascular anomalies, such as arterial usuria, so right subclavian artery from the left, and big carotid trunk. We should always, during surgery, identify the nerve, and based on the usual anatomical landmarks and awareness of the possibility of a non-recurrent laryngeal nerve, and this will minimize morbidity. I will show you now some pictures, some images of my CT in Portugal, Setúbal, and I hope you enjoy. Thank you very much.